Welcome students to the next session, which is beta adrenergic blockers or beta adrenergic antagonists. So beta blockers, in short, they inhibit the adrenergic responses mediated through the beta receptors. So you remember adrenergic receptors are of two types, alpha and beta. So we are going to discuss drugs which can block the beta receptors. Beta receptors are of three subtypes. We have beta 1, beta 2, and beta 3. So this group of drugs called beta blockers, they mainly act on the beta 1 and beta 2 receptors without much action on the beta 3, which is mainly present in the adipocytes. So all of them are competitive antagonists at the beta receptors. So this is the classification of beta blockers. We have first generation classical non-selective beta blocker. They are again without intrinsic sympathomimetic activity and with intrinsic sympathomimetic activity. So without intrinsic sympathomimetic activity you have propranolol, timolol, sotalol, and with intrinsic sympathomimetic activity you have pindolol and nadolol. Then you have the second generation, that is beta 1 selective blocker. It is called beta 1 selective, or sometimes it's called cardio selective also. Okay, cardio selective beta blocker or beta 1 selective beta blocker. You have metoprolol, atenolol, esmolol, acebutolol, bisoprolol, betaxolol, nebivolol, etc. And then you have the third generation, that is, they have additional actions. Okay, so they are beta blockers with some amount of alpha blocking property. You have carvedilol and labetalol. Before we go into the pharmacological actions of beta blockers, just brush through the beta receptors and its location. Okay, so it's very important for you to know the subtypes of each receptor and where it is found, where it is located. So beta 1 receptor predominantly present in the heart and also juxtaglomerular cells of the kidney. Then you have beta 2 receptor, which is mainly present on the bronchial smooth muscle, blood vessel, uterus, GIT, and the urinary tract. And beta 3 mainly present in the adipocytes. So beta blockers mainly act on beta 1 and beta 2 receptor, mainly block beta 1 and beta 2 receptor. Coming to the pharmacological actions of beta blockers, first is cardiovascular effects. Okay, so on the heart, what is the effect of beta blockers? So we'll be discussing the pharmacological effects with the prototype drug, which is propranolol. So it is the first beta blocker that came into the market. So propranolol can reduce the heart rate, myocardial contractility, conduction velocity, and cardiac output. Now all these effects are seen by blocking the beta 1 receptor in the heart. So it blocks the beta 1 receptor, thereby reduces heart rate, myocardial contractility, conduction velocity, and cardiac output, and they reduce or suppresses automaticity of the heart. So it is mainly prominent under sympathetic overactivity. The effect is not very marked in a normal heart, but when it is very prominent under sympathetic overactivity. Resting state, it does not have much action. It also abbreviates, propranolol abbreviates refractory period of myocardial fibers and can decrease the automaticity. AV conduction is also delayed. So all in all, it can reduce the cardiac workload as well as oxygen consumption, and it is very much beneficial during exercise. Effect on blood vessels. Propranolol produces fall in BP, but they do not have any direct action on the heart, and it does not produce any acute reduction in BP. Okay, only after prolonged administration it can reduce the cardiac output. So by acting on the beta 1 receptors, that is blocking the beta 1 receptors, it can reduce the heart rate and cardiac output. That is the main reason for fall in BP. But as I told you, there is no acute change. On prolonged administration, the vessels gradually become adapted to this fall in cardiac output. So the total peripheral resistance will reduce and hence BP also reduces. That is the main mechanism why there is antihypertensive action with propranolol and other beta blockers. That is by reduction in heart rate and cardiac output. There are other mechanisms which can contribute to this fall in blood pressure. That is reduction of release of renin from the juxtaglomerular cells. If you remember, beta 1 receptors are present on the juxtaglomerular cells of the kidney. So when you're blocking the beta 1 receptor, there is reduced renin release. So it is mainly the action is more marked in patients who have high renin level. Okay, so by reduction of release of renin from the juxtaglomerular cells, and also there is some amount of central action. It can reduce the sympathetic activity, and it can also block the presynaptic beta 2 receptors. If you remember, presynaptic beta 2 receptors are facilitatory. So when you're blocking those, there is reduced noradrenaline or norepinephrine release from the sympathetic terminal. So this image shows the overall cardiovascular effect, inhibition of cardiac function by reduction of heart rate, reduction of contraction, reduction conduction, and lowering blood pressure. Coming to the respiratory effects of beta blockers. So if you remember, it mainly acts on the beta 2 receptors. So in the bronchial smooth muscle, we have the beta 2 receptor, which is blocked, but it does not have much action in a normal individual. Mainly in asthmatic subjects, they can produce severe bronchoconstriction. So propranolol, by inhibiting the dilator beta 2 receptors, it is producing some bronchoconstriction or resistance. Next is the metabolic effects. So metabolic effects, propranolol and other beta blockers can alter the plasma lipid profile. It can increase the total triglycerides and LDL level. They can reduce the HDL level. They can also inhibit the glycogenolysis in the heart, the skeletal muscle, and the liver. Because of this inhibition of glycogenolysis, it can delay the recovery of hypoglycemia produced by insulin or anti-diabetic drugs. So when there is hypoglycemia, there will be sympathetic stimulation. So hypoglycemia symptoms will be delayed because beta blockers can inhibit the glycogenolysis. Effect on the CNS, they produce reduction in the sympathetic outflow. They can alter the mood, they can produce sedation, lethargy, disturbances in sleep. They can also suppress anxiety in short-term stressful situations. On the eyes, it can reduce the formation of aqueous humor. So it is very valuable in glaucoma. So it can reduce the intraocular pressure. So not propranolol. There are other beta blockers which can be applied topically in the eye for glaucoma. Other miscellaneous effects of beta blockers, they have membrane stabilizing property and hence some amount of local anesthetic action. They can inhibit adrenergically provoked tremors. They can increase synthesis and release of prostaglandins. They can prevent platelet aggregation and can promote fibrinolysis. And they can also reduce portal vein pressure. Coming to the pharmacokinetics of propranolol, they are well absorbed orally, but they have low bioavailability because of first pass metabolism in the liver. They are lipophilic and they can penetrate the brain. The metabolism of propranolol is dependent on hepatic blood flow. So chronic use can decrease the hepatic blood flow. Its own bioavailability is increased and the effect of T half is prolonged. The bioavailability of propranolol is increased with food because food decreases its first pass metabolism. Coming to the adverse effects of propranolol and beta blockers, bronchoconstriction by blocking the bronchodilatory beta 2 receptors, very commonly seen. Bradycardia is very commonly seen with propranolol and the beta blockers. They can precipitate congestive heart failure, hypoglycemia. They can lead to cold extremities. LDL cholesterol and triglycerides will increase and HDL cholesterol will reduce by long-term administration of propranolol. So there is higher risk of coronary artery disease. The cold extremities is mainly due to the blockade of the beta vasodilatory beta 2 receptors. It can also produce fatigue and impair exercise capacity by blocking the beta 2 receptor, increasing the blood flow to the muscles and also by impairing glycogenolysis. It can also produce sleep disturbances, bad dreams, depression, etc. Contraindications. These are the situations where you should avoid using beta blockers. Beta blockers should be avoided in severe bradycardia, in chronic obstructive lung disease COPD and bronchial asthma. Any patients with pre-existing high-grade heart block, they should not be used in variant angina. In cardiogenic shock, should not be used in Raynaud's disease and severe depression. Now, beta blockers, after chronic use or prolonged use, we should not abruptly withdraw propranolol therapy. We should not stop propranolol therapy abruptly after chronic use. Why? Because it can reduce rebound hypertension, it can worsen the angina, and it can produce sudden death. This is mainly due to the supersensitivity of the beta receptors. Okay, so when you're blocking beta receptors for a long period of time, it is not coming in contact with the agonist. Agonist stimulation does not occur. So when you suddenly stop the beta blocker therapy, beta receptors become super sensitive, leading to rebound hypertension, angina, and sudden death. Drug interactions very commonly seen with beta blockers. Propranolol with digitalis and verapamil, they can produce additive depression of the sinus node and AV node. It can lead to cardiac arrest. Propranolol and NSAIDs, when given together, NSAIDs can attenuate the antihypertensive action of propranolol. Cimetidine can inhibit the propranolol metabolism. Propranolol can reduce the lignocaine metabolism, and insulin and oral hypoglycemics or other anti-diabetic drugs that will be discussed in the next slide. So, drug interaction between propranolol and insulin or other oral hypoglycemics or oral anti-diabetic drugs. So, what happens with these drugs? If they produce hypoglycemia, propranolol can delay the recovery from hypoglycemia mainly by inhibiting the catecholamine-induced glycogenolysis. So that is one reason. Another reason is that when there is hypoglycemia, there is sympathetic stimulation which produces the warning signs of hypoglycemia like tremors, sweating, etc. So all the warning signs of hypoglycemia will be suppressed because all the beta receptors are blocked by propranolol. So you should be very cautious while giving propranolol with insulin and other oral hypoglycemic drugs. But in clinical practice, cardioselective beta blockers, that is, beta 1 selective beta blockers may be used safely in most of the patients with type 2 diabetes mellitus. With that, we come to the end of the first part of beta blockers. Thank you for your patient listening.